Good evening, everyone, and thank you for joining us for our Woo You event tonight with Dr. Susan Resnick. She's going to be discussing utilizing soft contact lenses in keratoconus. I'm your host tonight. My name is Dr. Arielle Sorenzi. So I am so excited to introduce our speaker, though a lot of you, I'm sure, have heard of her, read something of hers, or seen her present before. She is the president and managing partner of Dr. Farkas Castillo, Resnick and Associates. I probably butchered that, didn't I? Farkas? No? A contact lens and anterior segment specialty practice with locations in New York City and Long Island. She received her doctorate of optometry in the State University College of Optometry in New York. And she's devoted her clinical career of over 30 years to specialty contact lens fitting, ocular surface wellness, and refractive surgery co-management. She's a diplomate and committee sub-chair of the cornea contact lens and refractive surgery section of the Academy, the American Board of Optometry, and a fellow of the Scleral Lens Education Society. She's a frequent speaker and author on topics of specialty contact lenses and practice management, and she has participated in numerous clinical trials for the contact lens and pharmaceutical industries. She was honored by the Gas Permeable Lens Institute as a 2019 Practitioner of the Year. I was there for that. She was the recipient of the AOA Cornea and Contact Lens Luminary Award in 2020. So as a member of the SUNY Mentorship Network, she's been invited to speak at the Student Contact Lens Clubs, and she is devoted to mentoring aspiring and newly minted optometrists as they embark on their careers. So we're excited to hear from you on an exciting topic of soft lenses and keratoconus. And next, we'll just show the financial disclosures, all of which have been mitigated. And I will have you take it from here.
Well, thank you, Dr. Sorenzi, and thank you to everybody at New University for having me back. It's always an honor and a privilege. So, the way I'm going to present this is I think we've all been scleralized. So that means over the last several years, all our focus of keratoconus has been on sclerals. And I would be lying if I said to you that I don't love sclerals. I do. But I haven't lost an appreciation for the efficacy and versatility of soft lenses for keratoconus. And I love Stephanie's title for this series, and that's the keratoconic journey. And really, in my office, the journey still does start with considering the soft lens. And I'm not saying everybody will be a candidate, but tonight what I want to do is take you through what the options are in soft lenses. How are they designed? How do I match the opportunity of a soft lens with a particular patient? I'm also going to back in a little bit to how early diagnosis of keratoconus is important, how we do it, because as you might understand, soft lenses generally are most efficient and most productive in patients who are early in their diagnosis. But the other reason to diagnose them early, as we all know, is to get them cross-linked. So we're going to talk about how do we approach these contact lens wearers after cross-linking. Do we have to wait for them to be cross-linked? Can we do it before? And how does that impact their journey? I'm going to discuss how these lenses are designed, what the architecture is, how do we choose it based upon our clinical exam. And I want to try to gear this for everybody. So some of you may have a pentacam, some of you not. That won't matter because I'm going to try to come in at all levels. And then I'm going to end with a few cases. So let's jump in. The first part of this is an overview. So I call it know before you go. So soft lenses are best used in early, mild, stable cases. I find them particularly helpful in patients where I'm treating them monocularly. So let's say they have a form thrust keratoconus and they only need correction in one eye and they get pretty good uncorrected vision or spectacle vision in one eye. Having a soft lens in the other eye is fairly comfortable for them. Understand that both made-to-order and custom lenses are options. The custom lenses require diagnostic kits. The made-to-order lenses do not. You can order those empirically. Custom lenses will sometimes require longer physical adaptation than other modalities. And yes, sometimes more adaptation than sclerals, less adaptation than corneal GPs usually. Rely on your laboratory consultants, they're great. And just keep in mind, don't be afraid to just dive in. The fitting exchange warranties are very, very liberal, much like they are for scleral lenses. So, just keep in mind that you can start and you can start anywhere. And there are lots of different companies that do it. And in terms of, I often get asked, well, how many lenses or types should I deal with? You can start with one. I primarily use one, but you can use two depending upon the differences in designs. So what are the general considerations for soft lenses in keratoconus? Well, this can be somewhat objective, but I've tried to capture as many factors as I could in terms of the pros and cons. The real, I think, push for me in choosing a soft lens for patients is the psychological profile. The familiarity of soft lenses to patients makes them feel better. Patients come in very anxious, upset, depressed when they're first diagnosed. And if I can say, hey, Mrs. Jones, guess what? We don't have to go to a large hubcap, is what I sometimes call, I try to get them smiling and laughing. We don't have to go to a large scleral lens. We can use a soft lens, and their body, their face just relaxes. On the other side of that, though, is the referring ophthalmology, where they automatically say, go see Dr. Resnick. She's great. She's going to fit you with a hard lens. So sometimes I then have to kind of back out of it and say, well, I respect Dr. So-and-so's opinion on this, but guess what? You don't quite have to do what he told you. There's something we can do first. The other pros are that you don't need any extra equipment. I&R is technician friendly. Your technicians have been doing this for years. There's a shorter discontinuation period in soft lenses should they be fit before cross-linking. And it's definitely easier to monitor for disease progression because you don't have the GP lens pressing on the cornea. And even though we know scleral lenses don't sit on the cornea, it's my experience that there is still some, I'll use the word spectacle blur involved. And I believe that has to do with changes in the osmolarity, if you will, of the epithelium. I don't have actual proof of that, but I can tell you that I get better refractions on these patients after they've been out of their lenses for a couple of days as well. Fewer adverse events. I mean, sclerals are pretty safe, but I've never had any issues with soft lenses, keratoconic or otherwise. I think where they really don't come in quite as well as our hard lenses would be the visual acuity and the higher order aberrations. But keep in mind that not every patient is looking for a perfect 20/20. Some of them are just looking to feel normal and have good, adequate, usable vision. In my practice, cost, it's a wash pretty much. Comfort is good. And so there you have some of them. I'm sure you can think of others, but I just wanted to put some up. So what I've done here is I got a little creative and I did a little chart where I have the corneal condition on the left and kind of where I think our other modalities fit in. So we know we have soft, GP, intralimbal, and so on. So if we look on the left here at the custom soft, we see we're mostly in the green, which means it's a go. The yellow could be proceed with caution, and the red is where I would choose something else. So it's interesting, if you look at my thing here, custom soft, hybrids, and sclerals kind of are on par with one another. The boxes shift a little bit, but you can see that they're all excellent options. And again, the difference in what you choose is really the patient's psychological profile and some of the things that we're going to consider next. So let's get to that. So some of the things I consider are they a new or current wearer? If they've been in soft lenses and I can keep them in soft lenses, hey, they're very happy. What is the disease stage? And we're going to learn how to stage it in just a few minutes. And that goes hand in hand with refractive status because the best corrected spectacle vision is going to dictate where you're going to start in terms of complexity of the soft lens design, the patient's visual and lifestyle needs. Look, if they want to be able to go back and forth between glasses and contact lenses, I prefer a soft lens. If they are just looking to replace a reasonably good visual acuity with soft lenses, then often I'm fitting them with, just made to order lenses and not even keratoconic design. When I talk about convenience and care, some of them find soft lenses easier. When I refer to equipment, we all know the little kits we have to give out to our scleral lens wearers. It's a little bit more involved. Patient's dexterity comes into play. Some patients will find it easier to put in sclerals with a narrow palpebral aperture. That's not my experience. My experience is that soft lenses are easier. But again, I guess it varies. And then, of course, the cost difference. And again, I don't know that that's really a determination, so that's why I put it last. So how do we go about continuing to see the disease stage and diagnosing the corneal profile? So this graphic is actually from one of the manufacturers, and I stole it because I love it. And it basically gives you a general idea of what we're looking at in terms of the various types of ectasia. And so when you're fitting soft lenses, unlike GP lenses, it's almost definitely more like a scleral lens. In fact, some of the learnings from scleral lenses we're going to delve into with respect to soft lens design. We're going to look at sagittal depth. We've learned that base curve does not make any difference in these soft lenses because every manufacturer has a different base curve. It's the sagittal depth. So we want to assess the overall corneal shape, the degree of irregular cylinder or central irregularity. We want to know where the highest degree of ectasia is, the location. And so look, the underlying disease is important, but it's the corneal shape that you mostly want to deal with. So think about this. If you have a young, incipient nipple cone, that's going to be different from a post-LASIK early ectasia, right? Because an early post-LASIK ectasia is going to have an oblique profile. That's going to change the design of our soft lens. It may even change what you choose in terms of material, and I'm going to get into that more in a few minutes. So think of the overall shape. When we're dealing with ectasia, physiology doesn't really make that much of a difference unless we're dealing with post-surgical corneas where we're more concerned with oxygen. So for the purposes of tonight, I'm mostly going to be talking about early keratoconus and not post-PKPs. So that's why I have oxygen requirements with a question mark. In all my years of fitting keratoconic design lenses and using EMA materials, non-SiHy materials, I have not had any neovascularization in patients. And the reason for this, we're going to get into in just a couple of minutes. So I can't have a complete lecture without talking about Intacs, which are the bane of my existence. So Intacs had a very noble purpose, and I'm not saying that they don't help some patients, but they really make contact lens fitting more difficult. They often cause increased ghosting. Keep in mind that more central cones do yield better results for soft contact lenses. So you can see here on the left, preoperatively, the cone rides a little low. Once they put the Intact in, it actually raises the cone and makes it more central. And for some of our keratoconic designs, that actually becomes better in terms of our soft lenses. So for post-Intact patients, I actually find soft lenses work really well because I don't have to worry so much about the divot, about the elevation of the Intacts, about erosion. It's just a softer and gentler way, and I can design my curvature of my soft lenses to match the patient's corneal profile. I just wanted to get in a little bit more about the sagittal depth, and here was a great study using OCT. It was one of the original ones published in 2013, and it used the Visanti OCT. And what they did was they looked at sagittal depth at the HVID, which is usually, how we design soft lenses. And we also looked at 15 millimeters. And when you think of the way soft lenses should be designed, they should be designed with the HVID plus 2 to 3 millimeters. So this is very relevant. And you can see that there was a significant difference for these corneas at the steep meridian. There was about a 1200 micron difference. So standard soft lenses, just to bring everybody level set, generally have a sagittal depth of about 3,700. So we're looking at creating custom or made-to-order soft lenses with sagittal depths of at least 3,900. Also keep in mind that for a soft lens to stay on the eye, it has to exceed the sagittal depth of the eye by 150 to 200 microns. So now we're into the 4,000, 4,100. Just a little fun fact, researchers have found that the average corneal diameter based on OCT and the limit is 13.4 millimeters, even though most of the time we're taught to look at 11.8. So it doesn't really matter which one you use, but just know that you have to follow the manufacturer's direction in terms of that. So now that we know about the cornea and how the keratoconic cornea differs from the normal cornea, how do soft lenses, how are they built, and how do the custom designs differ from a general soft lens? So every soft lens has a base curve and a fitting curve. The base curve on these custom lenses are made to be steeper to match or vault the steep central curve. The fitting curve is meant to align the lens in the intermediate zone. So we'll describe that as like the 8 millimeter chord. The toric lenses are all stabilized, usually using elliptical, prism ballast elliptical stabilization. These lenses are manufactured with varying thickness. They generally start at about 2.5 millimeters thick, but they go up to, they can go up to 4 to 4.5 to 5 millimeters thick. So think about that. Some of them are actually thicker than scleral lenses. They're available in either HEMA or Sci-High. We're going to talk about that in a minute. But remember I alluded to before that I've never seen neovascularization. Why is that? It's because the lens edges are made very, very thin. Also, when we're fitting these lenses, they're going to move at least a millimeter to 2 millimeters with the blade. So it's not that little baby blink where we have to do a push-up test to see if it's moving. These lenses drape nicely. They're comfortable because of the edge design, but they do move so that there's oxygen exchange while the lens is moving. So just talking about materials now. The majority of these lenses, obviously they're all lathe cut. And there are two basic material groups. One is hyoxyphilcon. This is a glycerol methacrylate, which is a cousin of methyl methacrylate, for those of you who are old enough to remember. These lenses are non-ionic and they're resist deposits, and these are available in a few different water contents. They're dehydration resistant. They don't flex and they have good optical properties. That's why you'll see when you look in the contact lens spectrum or Tyler's and you look at the soft lens, custom soft lens categories, you're going to see that these lenses are made mostly in hyoxyphilcon. Some will be methylphilcon. The ephrofilcon lenses are the silicone hydrogels, and many of the companies now are doing that as well. And, more oxygen, of course, is better in our minds, but we know that some patients don't do that well with silicone. And for lenses that move, be sure you check under the lids for GPC. The edges are generally good, but you have to be careful. These lenses do have a DK of 60. The nice part about ephrofilcon is that it does have a modulus similar to standard conventional lenses. Now, let me back that up for a minute. So I had this nomogram, and I just wanted to show you how even a normal HEMA hyoxyphilcon lens, if you just look at the variations in water content versus the diameter, if we keep the diameter stable, and we're just looking at the same sagittal depth of the eye, for a lens with more water, we're going to have to go steeper on the same eye than for a lens of less water. So that's why it's important that you understand that the material characteristics of the design of the lens is under our control. We can control that, not like the little blister packs that we all know and love, and we learn to fit those, but those don't really have to be fit. These lenses do. So let's back into early detection of keratoconus, because that's really the low-lying fruit for fitting soft keratoconic lenses. So look at the epidemiology. So in the 1980s, when I graduated, I was 4. Okay, there should be a laugh, but we're virtual. So we were coded 1 in 2,000 back then, and that was actually defined as a rare disease. Fast forward to 2017, a study done in Norway showed the prevalence was 1 in 375. In 2020, we had another study, which was actually a review and meta-analysis published in Cornea. and they looked at like a zillion studies, and they found that globally there was 1.38 people out of 1,000. And now, if we extrapolate based upon the Gutenberg Health Study, in the United States alone, we can predict that there are greater than 870,000 patients or people with keratoconus. So that means that we are obviously diagnosing it better. It's not that there's more keratoconus. There's not more macular degeneration. We have better tools. So let's now talk about how we diagnose it early for two reasons. One is to get these patients cross-linked, and two is to get them cross-linked. That's where our soft lenses come into play. So just risk factors. The family history, the genetics play the biggest role. It's about double the risk of all of the other factors. But eye rubbing and atopy are also correlated with increased risk. So just keep that in mind. Early symptoms are usually the first clue. Look, if you have a patient in your chair and the first thing you do is the history, unless you're really progressive and proactive, you're not doing a topography on every patient before you see them. Maybe you are, I'm not, and I see a lot of keratoconus, but I'm listening about vision, how many times they've had to change their prescription in the last year, whether they've been happy with those changes, glare and halos around lights, and difficulty seeing at night. Now that, of course, is all of my cataract patients, but we're talking about individuals here in their 20s and 30s. Now we know keratoconus starts in early adolescence or late adolescence, but we know it's rarely picked up. So these patients often go to their 20s, 30s, sometimes even 40s before they're actually diagnosed. So let's talk about early detection. And again, I'm assuming most of the people here with us tonight have a topographer, but if you don't, you're going to look for asymmetric refractive error with higher progressive astigmatism. This picture on the right actually shows a scissoring reflex. And then you're going to see irregular astigmatism on keratometry. If you now go to early diagnosis, for those of us with placido disc topography, we're going to see mild asymmetric bow ties. The average K reading of an early keratoconic or the beginning or definite keratoconic is about 46 diopters. And then there's going to be an increasing difference between the inferior and superior corneal curvature with a maximum anterior elevation of 5 millimeters of about 27 microns. So this is just, for your reference. Even earlier diagnosis would involve using other indicators. So not using just a single parameter. So in addition to topography, we could look at pachymetry and we could look at higher order aberration data. So down here on the left, you can actually see root mean square values of higher order aberration. So for a non-keratoconic patient, it's about 0.25. But once we get to keratoconus in grade 1 and grade 2, we can see that it's about 1.5 or 2.52. And then I have some other data here that's taken from Schlanflug's or Bell Ambrosio grading scale, just for your reference. So again, the main aberration we can see is increased vertical coma. Now, the earliest diagnosis would be through your tomography. The minimum corneal thickness would be less than 473 microns. And keep in mind that corneal thinning typically occurs in the central or paracentral cornea, usually infratemporal. And then the earliest sign, which I think everybody probably knows by now, is in the posterior corneal elevation. The maximum elevation being greater than 48, almost 49 in the 5 millimeter zone. So why did I go through all that? Well, because I wanted you to have some idea of how to diagnose it early, which I'm sure most of you do, but it's nice to have real metrics. So we want to catch it early, and why do we want to refer nice and early for cross-linking? Because it halts progression of keratoconus, pellucid and post-refractive surgery keratoconus. Specifically, it halts the increase in steepness and the aberrations, can reduce loss of best corrected vision, and it can defer or reduce or obviate the need for further surgery. Now, we all know that patients have to be warned that having cross-linking isn't going to change much about their life in general. They're mostly still going to need contact lenses usually. Some can go back to glasses, but you have to let them know it's not necessarily to make them see 20/20. It's to prevent them from getting worse. So when do you want to refer? Basically, some of this is guided, of course, by guess who, insurance, but we don't necessarily have to wait, because if we see a patient who clearly has keratoconus and we have a record of what their prescription was, or can get a record of what their prescription was a year ago, there you go. You have proof that this young patient in your chair has progressed. So we're going to look at manifest refractive cylinder greater than a diopter of cylinder, or half a diopter of spherical equivalent, or a K-max that is increased more than 1 diopter. If they currently wear lenses, stop their soft contact lenses 2 to 3 days before, and their RGP lenses 7 days before. Now, that's just a general guideline. I would definitely encourage you to speak with your surgeon, get on the same page. The patients love it, just the way when we manage cataract surgery. You know, they listen to me, and will listen to you, and they're more interested in what you have to say than what the surgeon has to say. You're the doctor that's been taking care of them. You're the doctor that's going to treat their visual problems. Your surgeon is great. We don't want to take away from them, but basically it's one and done. You know, they're going to be in your chair a few days later. So let's talk about what you're going to have in your chair a few days later. Corneal remodeling occurs during the first few months. It will occur faster, obviously, with Epi-on than Epi-off. And we're still working on getting final approval for Epi-off here in the Epi-on here in the United States. But you do want to wait for the epithelium to be fully healed. What's happening physically? There's a decrease in basal cells and a decrease in the neural plexus density. So that's what creates the relative corneal hypoesthesia, and that can last for up to 6 months. So we want to be careful, because if the patients, it's almost like herpes, if their ability to feel or sense is down and something were to go wrong, it could go undetected for a while. So we want to wait at least 3 months before we fit them. And again, there is increased risk of microbial keratitis with mechanical trauma. So if that epithelium is not adhering very well to the basal membrane, they could get sloughing. So here you have a little scale. Here, reepithelialization occurs in 1 week, initial steepening in 1 to 2 months, and in the first year, you're going to have, or year to 2, you're going to have full healing. They'll continue to flatten for 24 months. The stroma will compact again, and you'll have surface healing. So that brings up the next question that I get, and that is, well, and I get this from patients as well as from our colleagues, is like, well, okay, so you're going to fit them in 3 months. You know, how do you refit them? What do you do in terms of the lens warranty? Well, the answer is you wait 3 months. If their vision's pretty good, you can wait 6 months. But generally, it's not going to change enough that you're going to have to refit the patient. And if you think about the warranty periods for these lenses, it's 3 months. So even if you at 2.5 months find a change, you still have time to order another lens. So I build that into my global fee. And, you know, my verbiage to the patient is, we're going to do what's best for your eyes, and we're going to work it out. And, you know, if I have to order in a lens or 2, I do it, you know, off warranty, but rarely does that happen. So now let's get into post-cross-linking fitting. And again, after that 3 months, or during that last 2 to 3 months, you're going to want to wait till the refraction topography is stable. If they have good vision with spectacles, you can use conventional soft lenses or made-to-order soft lenses. If there's ghosting with or poor quality vision with either of those, then we're going to go to custom soft. Now, be sure to stress to patients, particularly after standard cross-linking, that yes, their lenses may be expected to change over the next 6 to 12 months. So a little practice management pearl here. Many of these lenses are available in a quarterly replacement. I will generally order in one initial pair and follow the patient with that pair for 6 months before I start ordering as a quarterly replacement. It just makes more sense because with a custom lens, you can't take back all those lenses, as you all know. So now let's just look at general considerations when we're fitting soft lenses, whether they've had cross-linking or not, and just go into our general workup for these patients. So again, we're going to look at their refractive status. What can they correct to? What's the quality of vision? We're going to look at their topography. Remember I alluded before, where is the steep part of the cone of the cornea? How big is the cone? And that's going to help us with the design. If they have a small central cone, generally thinner lenses will work a little bit better than some of the others. They're all thick, but you don't have to go as thick. You will have to go thicker in low-lying oval cones. In terms of the ocular surface, it's the same concerns we have when we work up our patients for any soft lenses. In particular, look at the meibomian glands, look at the tear quantity and quality. It's particularly important to look at the quality of their blink. These lenses are fat, just like scleral lenses. They have to blink fully or they're going to get like a band keratopathy on the contact lens. In other words, deposits along the horizontal meridian in the inferior part of the lens. So pre-treat any pre-existing conditions. Please invert all of the upper lids. You want to make sure that there's no GPC. There can be more GPC when we fit sclerals. There can be more GPC for some patients in soft custom lenses. These lenses are larger diameter. Here's the ABCD criteria of the Bellin-Ambrosio scale. This came out in 2020. We use it now to stage the disease. There's another algorithm within the device that tells us if the patient is progressing. Some lenses actually have you start, their fitting sets will actually tell you to look at what stage the patient's in when you're choosing your original diagnostic lens. And again, I'm not going to go into each different brand. I can't do that tonight. But you can go and explore online, figure out what you might want to start with, and just follow the fitting guide. Generally, soft custom lenses will correct patients in stage 0 through stage 3. If you have a patient in stage 4, those are the patients that I typically will go directly to a scleral 4. You want to look at the cornea with and without dye. Now, when you're doing lid aversion, everybody knows what also goes along with keratoconus other than GPC. It's floppy eyelid syndrome, so you want to make a note of that. You're also going to want to look for corneal scarring because the last thing you want to do is fit your patient with a soft lens, see them 3 months later and see Neo and say, oh, look what I did to this patient when they had it there all along. Remember that corneal vessels, neovascular vessels, will grow into sick corneas, even corneas without scarring, but in particular corneas with scarring. So take a good look at the limbus and be careful not to gauge things that you see as adverse events of the lenses. Understand the underlying mechanism of the disease so that you don't start getting yourself crazy that you're the one that created the problem or that your lens created the problem. So if we look at standard and made-to-order soft lens criterion, mildly irregular corneas, centrally symmetrical topographies, minimal distortion. When I'm using these lenses, I'm looking for vision of 20/30 or better with minimal ghosting and only slightly decentered cones or central cones. For my custom soft lenses, those are the patients where more reduced best corrected spectacle vision. Know that you can get full parameter customization So not only can these be used in early keratoconus, but it can also be used to bridge the gap if waiting lamellar or PK surgery. So sometimes I use them at the end. And for these patients, I'm looking at best corrected vision with glasses of 20/60 or better. If I can't get that, then I usually will go to another modality, usually sclerals. So looking at the fitting method, again, each manufacturer has a different way. This one particular manufacturer has looking at the mean sagittal depth. Other manufacturers have you looking at the mean keratometry. Some of them have you looking at the tangential, the highest level of elevation on their tangential map. So again, they're all saying the same thing. It's just that they're having to use a different indices. So here's the thing. You gotta look at the first diagnostic pair after 5 minutes to make sure that this is the lens you wanna actually use. Otherwise, you've wasted your time. Allow that to settle then 20 minutes prior to over-refracting. AR is often not all that accurate. I use it because it's a good way to check relative differences, but I always do a careful spherocylindrical over-refraction. If the vision slowly fades after the blink, your lens is too steep. If it blurs immediately after the blink, your lens is too flat. If you see fluting, you can steepen the periphery. So you want to over-refract with any change in diagnostic lens. So for instance, some of the lenses I use are available with different thicknesses. I choose my first thickness, I do an over-refraction, and if I get a very good endpoint both optically and looking at the Myers, which I'm going to talk about in a minute, and I'm able to do it with less than, let's say, 4 diopters of cylinder, then I know I have the right thickness and I will use my over-refraction for that lens. If I put on a lens of a certain thickness or a certain design and I don't get a good endpoint, then I'm going to change the diagnostic lens and recheck the over-refraction. So your goal is to use the thinnest lens you can, but not so thin that you have to put in a ton of cylinder. Because we know that the more cylinder we put into the lens, the more apt it is to be fluctuating, even though these lenses are extraordinarily rotationally stable. So it's a pretty delicate balancing act, but the learning curve is not that great on these. And once you fit a few, you will have your own private algorithm. This is one company's way of steepening up or doing sector management. This is very similar to what we do in scleral lenses. You can modify one edge or 2 edges independently on some of these lenses. Other of the designs, you can change it by just steepening up the edge curve or making the lens bigger. You're going to want to look for feather touch. You can use for your silicone hydrogels, regular fluorescein if you want, or for your HEMA lenses, you can use high molecular weight. Just look for good alignment with the perilimbal area and the scleral, no limbal compression. Make sure the lens is centered. So what does this remind you of? It reminds you of fitting a regular soft lens. That's the beauty of these. And that's really the benefit to you, the patient, and your staff of involving in soft lens fitting, because it's just so familiar to all of us. So here are some pictorials of what you want to see. The middle one is what you want to see. A little bit of light central touch, adequate tears as that lens moves. Excessive tearing is going to create, remember we talked about the visual fluctuating after you blink, so you don't want too steep. And too flat, this lack of cone, you can actually also get abrasions. Certainly if there are any nodules, you want to make sure you go even a little bit steeper. So here's how I look to see if I've chosen the right thickness. I look at the Meyer evaluation. Love my Placido disc topographer as much as I love my tomographer. I'm able to see once you put the lens on, and you can see here the upper is before the lens, the lower is after the lens. So if you get Meyers that look like that, you know you've chosen the right thickness. And then finally, this was a study done by one design available in Europe, showing us and showing me what I discovered through practice, that these lenses can satisfy patients visually. So this shows the optical, the OPD and the HOAs before and after fitting. You can see that on the left. The top is before fitting, much fewer or lower, higher order aberrations. On the right, we have astigmatism, coma, spherical, and residual aberrations. The top is before fitting, and the bottom is after fitting. So studies have been done to show that soft lenses, via their thickness, via their masking, and in some cases via their draping, can definitely reduce higher order aberrations. Am I implying they're as good as sclerals? No. But again, we're dealing with patients that don't have the kind of aberrations that require sclerals. So let's just go through a couple of cases here. I think I have just the right amount of time. So I've chosen two cases to demonstrate what I see every day in practice. This first one was a mild stable cone. He was a high school teacher, and he had literally been diagnosed at the age of 33, 1 week prior to coming to see me. His medical history was non-contributory, and when I looked at him, his visual acuity without correction was about 20/70-ish in both eyes. You can see his manifest refraction there. And he corrected down to 20/40 and 20/30. And so, I'm thinking, okay, I'm going to try some corneal GP lenses because he'd never worn lenses before. As I was doing this exam, he didn't seem all of that sensitive. You can tell when you're kind of touching them, flipping their lids, and he seemed pretty cool with everything. And yes, I still fit GP lenses. But guess what? I put them on, and he's like, no, these are not for me. So then I thought, okay, let's try some soft lenses. And you can see his topography there. And while the cones look very big, they're fairly low and spread out. The curvature isn't terribly different. It is on it bisects horizontally. So the reason he was probably uncomfortable, as you can imagine, those GP lenses were falling a little bit. So I knew that I had enough normal cornea in the pupil that soft lenses might work. I did not elect to go right away to a custom design because I kind of liked what I saw. And when I showed him a spectacle correction, he was like, yeah, I'm good with that. So I thought, if he's good with that, I'm good with that. So I tried standard soft lenses, Omethylcon B, corrected him according to the manifest. There was no rotation, a little bit of over-refraction, but it didn't really make much of a difference in the vision, a little bit. So I wrote it all down because I like to have 2 data points, and I knew I was going to see him back. I dispensed the lenses with hydrogen peroxide, and the final prescription, when I added the resultant, which I used using a calculator, a special calculator, is what you see at the bottom, and he achieved 20/30 and 20/30 plus 2. So what happened was he had left with those original lenses, and when he came back, I added it, and that's what he was. I had 2 visits in there. Sorry. So now take a look at this. 5 years later, he's still happy. His comfort and vision is good. He was noting a little bit of redness at the end of the day. So he was already using peroxide disinfection. I didn't see anything on his corneas. So I'm thinking, at this point, what do I want to change? And let's get him more oxygen. So I went ahead and I just refit him in the same company's new silicone hydrogel. And as we know, silicone hydrogels have a higher modulus. So not only were his eyes white and quiet, but he achieved better vision as well without a change in prescription. So again, I didn't aim for gangbusters 2015 vision. I could have. I would have perhaps been hitting a fly with a hammer, but he's a happy man. And I've already said to him, look, if you need better vision at some point, we can climb the ladder in lens complexity. And that's how I left it with him. Just to show you, like 5 years later, yes, I've updated my equipment. But if we compare and assume that it's relatively consistent between devices, his steep axes have increased by about 0.75. He was 33. When I first saw him, believe it or not, cross-linking wasn't really a thing. So this is a case of way back, but I've been watching it carefully. And over many years now, he's been stable. He only increased about 0.75 in the first few years, and at 33, I mentioned to him about crosslink. I always give the patients the option, but he didn't really feel any great pull or necessity to have anybody mess with his happy eyes. So for the final case, this was a 48-year-old white female. She was diagnosed 2 years prior at a laser screening. Obviously, all of my new keratoconic patients come from laser screenings. I'm sure yours do as well. So she had a contact lens history. She had been wearing soft torics with dry eyes and soft vision. She clearly stated that she wanted to get better wearing time, but she still wanted to be able to go between the contact lenses and glasses, and she wanted better vision. So when I heard that, I immediately ruled out GPs, and I kind of ruled out hybrids because I find they muck with the vision as well. And so let's look at her intake information. She was seeing pretty well with her glasses, and she was kind of just looking to replace glasses with contacts. She didn't indicate she was unhappy with her glasses, but she had a ton of cylinder. She had intrastromal ring segments and cross-linking, and she had also had a CK burn in her right eye. And you can see in her topographies there, it almost looks like a pellucid after they had done the cross-linking and put the intacts in. So again, those were my options, and I decided to go with soft keratoconic design lenses for her. And here's a picture of one of her eyes with the intacts in. And of course, I was going to manage her underlying dry eye symptoms. So in this case, I used a keratoconic design and ioxophyllcon material. I used, you'll recall that she had more cylinder in that right eye, so I used what's called an incremental thickness of 2, which equates to 0.45 millimeters, an IT of 1.35 millimeters. I did the over-refraction, and then I ordered the lenses pretty much according to my over-refraction. She was getting 20/25, good movement, no rotation, a little bit of an oval refraction. I dispensed her, and then I scheduled her for a week to a week and a half, told her obviously to come in wearing the lenses. So she came in, she loved the comfort, she was wearing them a full day, she was happy with the vision, but she wanted a little better. So I repeated the oval refraction, and they were consistent. I calculated the resultant and came up with a little bit of a tweak. And I got her down to 20/20. I did not have to adjust anything else related to the lens parameters. So, those are just 2 examples of where I used just a regular soft lens on one eye. I didn't even have to go with a made to order. But on the eye that was more complex and with the intacts and with the greater cylinder, I used a keratoconic design. As I conclude here, I just thought this would be helpful to everyone. So when we're talking about lenses that we're using in terms of diagnostic sets in the office, everybody please remember how to disinfect lenses that you're going to be putting on multiple patients. This is true for both hard and soft. So for our soft keratoconic fitting sets, we're going to use straight 3% hydrogen peroxide with a non-neutralizing case for 3+ hours. You're then going to take the lens and put it in the regular peroxide system, neutralizing case, add your disc or your tablet, go through your regular disinfection as if the patient were doing it at home. Then you're going to rinse the lens, and you're going to store it in a multi-purpose solution. So everybody just remember that. So I'm going to wrap up. Why do we need to fit soft lenses for keratoconus? They're great for early to moderate ectasia. They're great for patients wanting a break for other modalities, part-time wear. Patients are less anxious. They feel more mainstream. For those of you who are just getting into specialty soft lens, to specialty fitting, wow, what a great way to start. You're going to be able to satisfy a good number of patients. You don't have to invest in ophthalmometry or anything too fancy. It's similar to fitting conventional soft lenses. And what I'm really looking to in the future are custom soft lenses that can correct higher order aberrations. So I hope it motivated a lot of you to reconsider soft lenses. They're your friend. We love our squirrels. We don't want to throw the baby out with the bathwater, though. So I thank you for your attention.